Hello, it's Dr. Bowen with Yodo again.
And I'm Dr. Lisa Tartaglia.
Today, continuing part of our serious illness topics, we're going to discuss prognostication for individuals with heart disease. So heart disease could be, that's a broad topic. It could be congestive heart failure, it could be coronary artery disease, it could be a valvular heart problem. In younger individuals and even in children, it could be a congenital cardiac abnormality. Typically, those are abnormalities the way the heart is made or the way the valves are formed. Many of our older patients maybe had rheumatic fever when they were younger, so they've been carrying maybe a lifelong valve problem that wasn't congenital, but they've had it since they were quite young. And eventually that heart muscle is beginning to tire and beginning to wear out. So heart failure, heart disease is a very common illness for individuals, and it's a very serious illness.
Yeah, and oftentimes patients, I found when I meet them in the hospice and palliative world, they don't even realize they have heart disease. We're going to see their primary multiple years. They may have seen a cardiologist one or two times when they were in the hospital, and they just have all these blood pressure pills. And they're like, what happened? We'd have all these pills. And when we break it down as clinicians, as physicians, we go through the classes of medications, and we're able to see how sick the patient is based on how many classes of medication the patient's on.
Many times patients think, when I was 40 and I started on a blood pressure pill, and then when I was 50 they added a second one. Sometimes patients feel like they should have just put me on a different medicine because I became immune to that one. And that's not exactly true. You needed a second medication because of the natural progression of that disease process. So one medication, even a really high level, is not going to be enough, and just switching you from one class of medication to another is not necessarily going to be enough. So sometimes you need something like a beta blocker that will help control the rate and the squeeze of the heart. Sometimes you may need an addition of a diuretic to help remove extra fluid. Sometimes you may need a calcium channel blocker, which works on a totally different mechanism to help your heart. And then there's another class of medications, ARB, ACE, but the ARB and the ACE class, and sometimes they'll even combine those, even though they work very similarly on the kidney system, the angiotensin renal. Thank you. Well, we'll just skip it. On the ACE-ARB system, we're not going to get into pharmacokinetics, but they work a separate way on the kidney system to help the blood pressure be more normal, because high blood pressure is not good for us. We would like a blood pressure to be on the top side between maybe 110 and really not much higher than 140. And really that bottom number, we would like to see that between maybe mid 50s and maybe high 80s. We don't really want it higher than that. We base that on when somebody's seated and relaxed and has been seated for a few minutes, that we take their blood pressure in their arm, because we know that that's kind of the standard. When you're upset, when you're in heat, when you're stressed, when you're working, your blood pressure is going to go up. So I know that if they check my blood pressure today when I go to see the doctor, and Dr. T tells me, oh my gosh, your blood pressure is 160 over 90 when I'm seated and at rest, how high do you think my blood pressure is going to go when I'm chasing after the postman, or when I'm out in the heat by the roadside changing a flat tire? It could go up tremendously, and we see that during a stress test. We put a blood pressure cuff and all kinds of leads on people, and we start that stress test machine out, and then the better they do, the steeper the incline and the faster we make them go, and we see that blood pressure climb. So if a person's blood pressure climbs to 240 over 120 when they're stressed, they may have a problem with that. If they're already high, we know it's going to jump even that much more in a stressed situation. So we want their blood pressure to not be so high to begin with, because that makes the heart muscle change over time, and that can lead to a heart issue, heart disease, and heart failure.
Right. And now there's a lot of treatments out there for a heart, which earlier on in my career were not
not available.
They've modified a lot, and they do a lot outpatient for patients. So they can even they might say, listen, we need to do a cardiac catheterization to look at the blood vessels. And, back when I first started training, you were doing those more as not preventively, but more because there was a problem with the heart, like somebody came in already with a heart attack. Now I find that patients are getting this done before the actual heart attack. Let's look at the vessels so then we know what other medications to add or what type of heart disease you really have. Then we do echocardiograms to look at what type of heart failure do you have, all these testing help us prognosticate and help us to treat the types of heart failure, because years ago when I first started my training, they didn't really have a separate diastolic and systolic heart failure. Now there's been so much in the last 20 years evolving with cardiology that we now know there's different types of heart failure.
And you treat them differently.
Exactly. We just had one treatment, diuretics, But no.
So we can look at a heart, and because people say, I had a heart test. There are many heart tests, and let's talk just a moment about that. An EKG or ECG is the electrical activity of the heart. And what does the electrical current look like as it sends that spark of activity through the heart? Does it go through there the appropriate way? Does it show that there's damage in there? And we know what those normals are supposed to look like when we do an EKG. And that's just that simple test where they put all those little stickers on your arms and your legs and across your chest in a particular way, in a particular location, so that they can see what that electrical current looks like. Each one of those electrodes is basically an eye, and it watches how that current comes toward it or goes away, or how that current crosses in front of it. And so we have to have all of those electrodes, and there's 12 different eyes watching how that same electrical current goes through the heart. That's what an EKG is, and it tells us if there's damaged tissue. But an echocardiogram is a different way of looking at the heart.
It's more of an ultrasound, so we're looking at the heart as a whole, as an organ, and you can see by the different shape of the heart what type of heart failure or what type of heart abnormality we have. Are the atriums enlarged? Are the ventricles enlarged? Are they thickened? Are they thin? Are there valvular defects? Like there's different valves of the heart. So certain valvular defects may cause a filling problem to the heart, or it may cause an ejection problem. We look at the ejection fraction. A normal ejection fraction, it does not show problems of the heart, but the smaller ejection fraction, as the ejection fraction gets less and less, it shows us that the heart is not ejecting blood correctly and will cause heart failure. However, sometimes a higher ejection fraction can show a filling defect, a diastolic heart failure. So what that means is the blood is not able, there's a filling problem to the heart. So the heart cannot function as well because it's not getting the blood flow to function properly.
What's the thickness of the heart muscle? So you think, I want my heart muscle really strong. But if it's so thick and so stiff that it doesn't relax well to let it fill, because your heart is basically, just squeezing. And when it squeezes, the valve is supposed to close so the blood only goes the one way, and it doesn't backwash. So if you've got a bad valve or a stiff valve that won't open all the way, it won't let the blood in, or won't close all the way, or if the muscle is so thick that the cavity for the ventricle, for the atria, is just too tiny, it might have a great ejection fraction, but you're only getting down a small amount because you've got this great big muscle, and maybe the great big muscle is so thick and stiff that the heart won't relax well. The echocardiogram is going to give us a lot of data about how the heart muscle is made, what the structure of it is, and what the valves are. But it's not like an EKG at all. It doesn't give us the same information.
No, because it does not show electrical current. There's also different types of cardiologists. Like, I'm just thinking this as we're recording, a lot of times people just think, I go to a cardiologist. Then you'll start to talk to them, and they're also seeing an electrophysiologist, and that means that they have a problem with their EKG, to dummy it down, the electrical system. And then they will see an interventional cardiologist if maybe it's more of a mechanical issue. And then there's the cardiothoracic surgeon. There's a lot of different pieces to cardiology. And there's a lot of different classes of medication, like Dr. Bone was saying earlier. So if you're back to the echocardiogram, if your muscles are not working well, sometimes we use the calcium channel blockers to help with the musculature of the heart. That's why they choose that class of medication. If your muscle of your heart is not working well and the valves are not working, you have regurgitation. So people will be like, oh yes, I have mitral regurgitation.
I have a leaky valve.
I have a leaky valve. Or they have stenosis, which means it doesn't close well. So there's a lot of information just by looking at the heart.
So the EKG tells us the electrical, and the echo tells us about the heart muscle itself. But one thing we haven't really talked about is, how do you know that the blood vessels that go to the heart are actually open and giving the heart the blood it needs? So everybody thinks, well, the heart has all that blood in it, but that's going through there so fast, it can't even feed the heart muscle. So the heart that gives you the circulation to your body, it also has circulation. It has its own blood vessels, and there are their own tests to evaluate those heart muscles.
Right, and they're used, and when there's abnormalities with those vessels, sometimes that's when you hear of chest pain, and that's when patients have the heart attack.
Angina is the definition of angina is the cry of the heart for more blood. And you're thinking, it's got all that blood inside of it, but it doesn't feed the muscle cells itself. That's inside of the cavity of the heart. So you have the blood vessels around the outside. And when they do a test to evaluate that, that's when they have the little catheter, cardiac cath. They'll feed usually in through an artery in your thigh, and they will cannulate all the way up to your heart, and then they will put a little amount of dye, and they will watch on the camera how that dye goes through those heart blood vessels. Not through the heart or the muscle or the electrical system.
It's just the blood vessels. So if there is a blockage, they can put a stent in, and they do it in real time. If there's several areas of damage, then cardiologists may say, okay, well, we have to send you to the cardiothoracic surgeon, and you're going to have a cabbage and a bypass surgery to graft different vessels and allow the blood flow to re-engage and hopefully get the heart back to its baseline. With that being said, as we said earlier, they're doing these cardiac catheterizations even outpatients, an outpatient procedure, kind of like going in for an endoscopy. So a lot of times people don't even realize how sick they are to even have this procedure. And getting a stent is like, brushing your teeth to some cardiac patients.
They've gotten so good at doing it, and you're given some medicine to make you drowsy, but you're not like intubated, you're awake.
And you go about your day,
So once the heart gets damaged, and it's damaged beyond repair, and the medications are helping but not making it better anymore, now we need to talk about that prognosis for that individual. And we look at several different factors. One of them is the New York Heart Class. And you can Google New York Heart Class. It's 1, 2, 3, and 4. And basically, Heart Class 4 is when we start talking with patients about their palliative care, about potentially being eligible for hospice care, because their heart is needing so much help to work, and maybe the medications aren't enough anymore, and they don't have any other options. Their valve can't be cured. They've maybe had a valve replacement, or they can't do a procedure on that valve, or maybe the damage to the circulation is just so bad they're having severe symptoms, even symptoms at rest. They get that chest pressure, which could be heaviness in the chest, heaviness in the jaw or neck. Sometimes patients will say my arms get tired or my shoulder aches. But the New York Heart Class talks about the severity. The patient's already on their maximum amount of medications, and they're short of breath when they brush their teeth.
Yeah, and these type of patients, sometimes it just progresses very quickly. Where they may have another event like an infection that brings them into the hospital, and then they have an exacerbation of their heart condition, and then they do not return to their baseline.
Sometimes an individual is doing very well, and I'll tell families, their health, even though they've been doing well at home, their health has been balanced on the blade of a knife. And now they got that infection, they had a fall, something happened, that just tipped the scale a little bit. Or maybe they had a little silent heart attack, but something tipped it just enough to add one more straw to the camel's back, and now they can't bear that burden anymore. Maybe now they've had a kidney infection and their kidneys are no longer able to tolerate that medication that was helping their heart. So you got a medicine they need for their heart, their kidneys can't stand it. The kidney can't take it anymore. So sometimes one organ system will pressure another organ system, and we just don't have that technology at this point in time to correct that.
Right. And as people advance in age, it's normal for their kidneys to age. And unfortunately, cardiac patients, their kidneys age quicker. Just like anything, if they have a cardiac illness because they're not getting good blood flow to their heart, then other organs are going to have end organ damage. Their colon, as they get older, can be affected. The kidneys can be affected. The liver can be affected. So you have to look at the whole picture and know that as we advance in age, sometimes this is going to just happen, and it's inevitable. We try to prevent it, but it's inevitable.
How is their circulation? Do they have cold fingers? Do they have a weak pulse? Do they have a good pulse in their feet? Maybe it's really weak in their feet. Maybe they have circulation problems and discoloration to their lower legs. Maybe they have edema. Maybe they have swelling in their lower legs. And we try to give them diuretics, but their circulation is so poor that they can't tolerate the diuretic to alleviate some of those symptoms. So they may have cough, they may have shortness of breath, they may have edema.
Yeah. Do they have underlying diabetes? Like diabetes plays a role because that affects the kidneys' function, as well as good glucose control. If you don't have good glucose control, then it can cause exacerbations of other chronic illnesses. There's a lot of things that we look at, and the big thing with cardiac was fatigue, right? We see it a lot, but sometimes physicians do not see it. When they just come in, see little Miss Mary Susie comes in for her appointment. She's getting by walker. Well, she's been using a walker for years. It's no big deal.
We may not see her walk in the room.
Yeah, we don't see it. She's already sitting down. She's already had her vitals done by her medical assistant, and we go in. Clock starts. What does physicians now have?
Yeah, say 15 minutes.
Yeah.
Sometimes not that.
Sometimes 10. And they have to go through things very, very quickly. And it's not because, they want to have a long lunch, Dr. Bone, is it?
No, it's just that's the way the system is.
Yes. So we don't notice the fatigue of the patient. So it's really important, as we've discussed in our other serious illness videos, to talk to the patient. Find out what they were able to do 6 months ago as to now what they can no longer do.
And the patients can help that by having a list.
Yes.
Having their questions organized, having their meds organized, so that when the patient and the physician do finally get to have time together, it's valuable time. So in prognostication, the physician needs to talk with the patient about the multiple symptoms that they could be feeling at home that help guide that physician as to what do we do next and where are we in this disease process. Because certainly we can do all these tests, but tests are not the only thing we need to know. We need to know from the patient and the family what is happening, because some of these symptoms could be something like shortness of breath, could be chest pressure.
Right. Weakness, generalized fatigue.
Even cough.
Cough, yeah. The ability not to lay in bed anymore. They have to sleep in a recliner. Sometimes there's appetite changes with really severe cardiac disease. You start to see people.
They don't want to eat.
Not being able to eat because
feel like they get full too soon.
Because of either their chest pressure that they have the fullness, or just that their underlying fatigue. It takes too much out of them to eat.
They may have symptoms like I feel like I'm gassy, or I feel like I have heartburn. When my dad had heart disease and he had angina, he said it's just a heavy sensation in my chest. I feel like if I could belch, I would feel better. Right. And of course, belching didn't make him feel better, but that's how his angina behaved for him.
Yeah, and sleep changes in patients can also, with cardiac patients, they have a hard time falling asleep because they're so short of breath if they're not in an inclined position. So if they cannot fall asleep, their day and night cycle gets off, and then this even affects them when their normal activities of daily living.
Sometimes patients will have angina at night that will wake them. Exactly. It might feel like they've got pain between their shoulder blades, or aching in their shoulders, or pain in their neck or jaw, but the angina itself will wake them.
Right. There can be skin changes found on end-stage congestive heart failure patients that have chronic edema. These skin changes over time, if God forbid, if they hit their leg, walking, and their skin opens, then there's an infectious process. This is very hard to treat in our end stage.
So what she's describing is the patients have this, gravity pulling down on them because they sit in the chair or in a recliner a lot. They're not flat in a bed often. And they can get this, what we call dependent rubor, where their lower legs, pretty much maybe their feet or their ankles or maybe even partway up that lower leg, is a deep red. And when you touch with the back of your fingers, it's not red like it's hot, like it's infected. It's just like it's stained red now. And sometimes that fluid has been in there so long, we call it woody induration, where it's not like pitting edema where you push in and it's like pressing on a sponge, but that fluid has been in there for so long that they can't get that fluid out anymore.
Right. No matter how many diuretics and the different classes of diuretics you use, it stays into the system. And then I find that those patients also are at high risk if they, like I've said earlier, if they hit themselves, that area of skin breaks down very easily because of the blood flow.
So pressure stockings, TED hose. Nobody likes TED hose, or nobody I know likes TED hose because it's squeezing your lower leg. And some people will think, well, I just need to put those TED hose on. The key to wearing those support stockings, they're supposed to prevent fluid from getting into your legs. They don't squeeze it out. So you need to put those on before you put your feet on the ground first thing in the morning because the water that's in there is now trapped. So if you don't get the fluid out, it actually holds that fluid in there. So you've got it toes above your nose, so gravity is working to pull that fluid back into your body. Put those TED hose on, and then you can get up. Because if you're up for an hour, you've already got fluid in your legs. You put your TED hose on, now you trap it in there for the day. And TED hose that end at the knee they act like a big tight rubber band on your leg. They're going to not only squeeze that and hold it in there, but you're going to get this big indentation just below your knee. And some people say those make my knees ache and hurt.
Right.
We really like the ones that come above the knee. And you think TED hose, you don't like TED hose, wear those thigh high, and you'll find out what true hate really is, because you will hate those TED hose.
They're very uncomfortable and
hot.
Hot. And what you don't realize is our patients are already debilitated.
And trying to pull those on.
It's like a cardiac stress test on a daily basis for these people. It's really sad.
But they can do a lot of good for people to a certain point. And then you'll reach a point where the TED hose won't do any good. They're actually worse, and you can't get them on. I've seen where patients, family members have tried to pull those on and accidentally with a fingernail unintentionally scraped that person's leg like Dr. T was talking about, and then that fluid wants to come out of that hole just like a hole in the dike. Right. And trying to get that to heal is really a chore and can take a long period of time if it ever heals. Yeah. So weakness, energy changes, sleep changes, of course, tightness in the chest, cough, shortness of breath, those are all factors we can't measure. Those are all subjective things that are told to us by patients, that we take that information, look at what these other tests have told us, and then we can help that patient and that family prognosticate about where they are in that disease state, how advanced that stage is, and what we need to be doing to prepare that patient and that family so that their lifestyle can be the best that we can provide and that they can be as comfortable as they can. So we don't want to deliver bad news, but sometimes we need to help those patients and families understand where we are in that disease process. We want you to have the best life we possibly can for as long as we possibly can.
And I think it's important to know that in the disease process, if we are living the best life that we can and functioning on quality of life, sometimes quantity just comes along with it. And a lot of times patients are so caught up in all the testing and going in and out of the hospital, and because this has become a way of life, that they've stopped living. They're living test to test. So so we always talk to our patients and really figure out, what do they want? Some people do want test to test, and they want to be in the hospital. I mean, that's just the way it is. And then there's others, more often than not, by opening Pandora's box and talking about these symptoms, we're able to really see what they want, and they want to be with their family. Mm-hmm. They want to be eating what they want to eat. If they want to have a potato chip, it's not going to kill them. Let them have the potato chip. We'll diurese them. We'll work with them. We'll symptom manage them. Let them enjoy their time with their family.
I think that's well said, and I think that's good advice. So talk with your providers, your physicians, your teams, and let them know what those symptoms are.
Thank you so much for joining us. We hope that we helped you all that have family members, or even if you yourself have cardiac issues. Please drop us a line in the chat. Send us an email if you have any further questions. And we look forward to seeing you again in our next serious illness
Thank you.
topic.
Bye now.
Bye now.